Welcome to our webinar, Innovating with Data, Accelerating Digital Transformation for Improved Healthcare, with thanks to our sponsors, DELL Technologies. Now, we have the Health and Social Care Bill, as well as a new data strategy to look forward to. So our topic today is timely. COVID has accelerated digital transformation, which depends on data. How can we harness all of the data in our health and care system? How do we ensure that we do so equitably, ensuring citizen trust? How can we innovate with data and drive digital transformation? How can we develop the next generation of data-centric digital services? I'd love to have your questions in the Q&A. Please put them in as we go. I have a wonderful panel. You'll notice that when we did the advertising, and you'll see it there, we have the Twitter handles available. So please get in touch with the panelists after this event. I'm going to ask each of the panelists to introduce themselves in turn. I'll begin with Masood, if that's okay. Masood, please tell us a little bit about yourself and where you come from.
Hi, so I'm the Chief Medical Officer and CCIO for the Black Country in West Birmingham CCG. So we will be becoming an ICS next year, and we serve a population of 1.5 million people, and certainly with my digital hat on, I contribute to our digital strategy. I'm also supporting the West Midlands AHSN as their clinical technology officer, so a keen interest, if you like, in innovation, adoption and spread. So really pleased to be here and looking forward to the discussions that we're going to have. Thanks, Hassan.
Thank you so much, Masood. Victoria, over to you. Please tell us a little bit about yourself.
Thank you, Hassan. Hello, everybody. I'm really delighted to be here. So my name is Victoria Betton. I have my own company, PeopleDotCom, and I work pretty much exclusively with the NHS and with charities, helping them innovate around sort of digital strategy, commercial spin-outs, adoption, that sort of thing. My background way back is as a social worker. I worked in the third sector local authorities before joining the NHS. And I've always really been interested in human factors, so the unintended consequences of technology, health inequalities, and all the people stuff that's so important but sometimes gets forgotten about in the tech discussions. So that's me, thank you.
Thank you, wonderful to have you here. And Amy, please tell us about yourself and the wonderful things that you're doing.
Hi, so I'm Amy Davis. I'm a consultant radiologist in the NHS, and I'm also co-founder and CCO of Hexarad. Hexarad is a technology-focused, radiologist-led teleradiology company, and we've got the belief that improving the technology within our company can help drive clinical quality and efficiency and help overcome the capacity and demand problems that we're seeing within radiology.
Thanks, wonderful to have you with us, Amy. And finally to James, if you wouldn't mind introducing yourself and also give us a bit of a lead in to the topic from your perspective.
Thanks, Hassan. So James Norman, I'm the Healthcare CIO within DELL Technologies for the EMEA region. I've come from the NHS, spending most of my career working in different areas around IT, information, and in healthcare at a trust level and in the department as well. So I've had a broad experience before moving into the private sector. And I've now been part of DELL Technologies for the last 8 years, working with customers around their digital transformation strategies, but also helping to them to understand how they can use technology to improve outcomes for patients. So it's not just about implementing a new system, but it's about that whole change process as well, which really leads us to the point of this webinar today, which is, there's a lot going on the back of we're coming out of the first 3 lockdown waves for the pandemic. We've learned a lot over the last 18 months about how we can change the services we provide across the NHS using technology to enable improved access to services and really reshaping how the future of the NHS is going to be moving forward through the use of the greater use of technology, and also the better use of the information that's being captured to help prepare us for future pandemics. So one of the key challenges that we've faced in the past is that we capture lots and lots of different types of data from patients, from operational outcomes, third party, social economic data. We've been struggling to bring that data together in a way that makes and allows us to get real insights that allow us to change the way that we provide care. This is partly due to the legacy applications that have been implemented, partly due to policy, GDPR, the Caldicott rules, the interpretation about what can and can't be done with the data that we've got. And basically, we're a very risk-averse organisation within the NHS. So really, change has had to happen to enable people to understand how to use that data to really reshape where the vaccines went to understand the progression of the COVID disease and what was happening as we move in now, looking forward at the long COVID and the impact of people who've suffered from the virus, how we go about supporting, conditions and transfer of care there. We need that data. We need to make sense of it. But it sits in silos in different areas. It sits at a local level in the trust, in the GP practice, the Department of Health and NHS England, NHSX and NHS Digital. They're all working together to try and bring greater intelligence from that information. But the problem is the information is evolving as we move forward. And as we find out more about the disease and more about what we need to do, we realize that there's more data that needs to be captured or it's coming from a different source. And really, the NHS just doesn't have the to bring all these disparate data sets together in a way that allows it to make sense of it rationally and easily to push that back out and make change on the back of it. We've seen lots of initiatives in terms of, well, let's go out and let's get big electronic medical record systems so we can have commonality of data across an organisation. That's great, that's improved patient flow, but it's not improved the flow of activity across a health economy. Where we brought in the care record and through the LICA, the ability to share data, again, we saw big advances in the ability to move activity to where the patient and services, but it was at a health economy level. It still didn't enable that capture of data to really move services and actually reshape the services. All we did was move people to where the service was being provided to make it more easy to access. So now we've got an opportunity to really reshape what's going on by looking at the lessons we've learned over the last 18 months, understanding how, on the back of the data strategy and the new health and social care bill, we can really change the way that we utilize the data at a local level and capture that and make it available at a national level for everybody to start learning from the lessons. How can we make that available appropriately for higher education and research so that we can improve our own research capabilities? And also working with third parties such as pharmaceuticals to understand, on new drug development, how can they take advantage of the richness of the data that we've got, but again, without sharing patient data and doing so in an appropriate way, but gives us that agility to move forward and be ready for the next pandemic.
Thank you so much, James. That was insightful, but worrying, right? It's troubling that the system has gone so far, but still has so much left to do. Once again, a reminder for everyone attending, please put your questions into the Q&A. Our panel is going to be ready to take some questions. I'm going to ask James a quick question, then I'm going to open it out to the floor. James, you mentioned, and I also mentioned the data strategy, the health and social care bill. We've had lots of things come up now. I mean, GPDPR, the so-called data grab with NHS Digital. Do you think that there's a lot of concern about where we're going with data, especially when it comes to citizens?
Yeah, no, absolutely. So everyone has a memory of the care.data program and what happened back, in that time where there was misinformation that came out about how the data would be used, who it would be shared with, scaremongering about the data being sold off for profit to third-party providers. But you know, patients' data would suddenly be made available for other people putting it at risk. There was also concerns brought in about, well, actually, if you're using my data, shouldn't I get paid for it because I control the data? So there was lots of discussions about where does the data sovereignty live, you know, and concerns around that side. So with all the changes that are happening now, we're seeing a resurgence of these questions, you know, which are going to need to be addressed in terms of, you know, does the patient own the data? Do we have to have social contracts with the patient around the use, appropriate use, consent? How is that being managed? You know, do we put in consent purposes? You know, do we need to change the law, which is you need to opt out? You know, there's so many different aspects which can derail change. Ultimately, though, it's around the culture and the adoption and, you know, people's willingness to use the data appropriately, but, you know, give their data up for these services as well. And this is one of the reasons why we wanted to focus today on, you know, the different areas around health inequalities and the appropriate use of data and what it can mean, but also with the changes coming on with the integrated care systems, which will come into force, you know, in April. You know, there's a real opportunity to start reshaping services at a local level, linking that into the work that's going on with NHS England and D. But also, we need to understand from a clinician's perspective, and this is why it's great to have Amy on the call as well. What does this actually mean for, you know, the clinicians in terms of the use of data and how that's going to be shaped? So, you know, some really big topics that we need to address, and the epidemiology side in terms of, you know, disease, treatment pathways, understanding the reshaping of care pathways. All of these need to be brought in together.
Thank you so much, James. Now, your answer made me think about going to Masood first and then to Amy. But Masood, you're Chief Medical Officer and Chief Clinical Information Officer for a massive set of combined CCGs. What are patients and citizens telling you? What are frontline staff telling you about this?
I think in terms of patients and staff, one of the things to recognize is that the data that we talk about, it's a little bit overwhelming. And it reminds me of a quote, if you like, from an economist, Herbert Simon, where he talks about a wealth of information creates a poverty of attention. And so this concept of kind of, we are in an attention economy where actually there is so much noise. How do you filter out the noise so that actually you get the right data? And then how do you have trust in that data so that you can then leverage it as an enabler? And I think, you know, from a clinical perspective as well, one of the things that is often a concern is we talk about, you know, decision making that is data led. And actually, I would say there's a nuance to that. And it's actually about being data informed decision making, because we have all this data. How do you make sense of it? How do you know you're relying on the right data sets, etc.? And that's where things like, you know, machine learning and AI come in, because they start to kind of filter that noise so that we have that focus. And then I think we then, you know, engage in all the other areas that James has talked about in terms of how it's utilized, how it's leveraged, how it's, you know, used by patients, by clinicians, by organizations, when we're looking at it from a system perspective, and that leads into the whole population health. So we're on a journey, but we really need to be clear about what are the checkpoints along that journey, so that we're making the right decisions, we've got the right considerations, rather than being overwhelmed and saying, oh, this is great, we've got all this data, we've got, you know, these opportunities. Because if it's not joined up thinking, then it's a bit like the internet, that, you know, the internet was viewed in one way when it was created, and now it's this behemoth which does so much, it's unregulated. Where do we go? And actually, I think one of the interesting statements that was made was recognizing the unintended consequences. And that's what we've got to be really careful of. If we don't step back, pause and think about what we want to do, what the opportunity is, then there's a risk that we will start to go down rabbit holes and we'll go too far before we pull back and think, hang on a second, did we really think this through?
Thank you so much, Masood. So, Amy, I've got that same question for you. You're actually at the front end, right? You're using data. You're actually doing things with making decisions with data. Love to hear your perspective, and I'll go to Victoria straight after.
I just had a couple of points to come back to James and Masood on. And you mentioned AI and the usefulness of data and how that can help clean up the data. But actually, there's a little bit of overemphasis on how good AI can be in terms of the data, because it's like anything, you get out of it what you put in. So if the data you're putting into your AI machine learning, the algorithms is messy in the first place, it actually ends up not being as helpful. There was a relatively well-known paper a few years ago, which was looking at breast cancer mammogram screenings, I think, and the AI machine basically learned that all the patients who were normal had come from one place, and so that's what the AI machine learned. It didn't actually learn to read the mammograms; it just learned everybody with this hospital address is normal. And then there's been some more work recently, I think mainly in the States, looking at that AI actually has inherent racism in it as well. I don't really understand how that has come out that way, but it's not really going to save us in terms of the data. We still have to really think about what we're putting in terms of what we're going to get out. And I can't even remember what my point was. Back to you, James. Sorry, waffling on.
No, that's all right. I mean, that bias that gets into the data, is something that is a real challenge. And the example you just gave there about racism in the data. It's very easy for false data to get into the data sets and to taint and change the algorithm as it goes along. And these are part of the checks that need to be put in. And to be perfectly honest, this is part of the reason why there needs to be a new structure and a new way that we use the data. It's not just about, let's take the data, let's put it in a big database and let's get some analysis on it. There needs to be the balances and checks in there around the security of it, understanding the type of data that's being captured at the metadata level, being able to structure it in a way that you can make sure that there is appropriate use of it, but also that you're checking for this bias that's coming in. And we've not even touched on ethical use of the data as well.
Just one anecdote, if I could. Chair's privilege here. There was a company that was looking at melanomas, and in order to test the algorithm, they fed the machine lots of images, and the machine learned that if there was a ruler in the image, then there was a melanoma, because they'd left the ruler in the images. Victoria, I'm so glad I'm coming to you at this point of the conversation, because I think this touches a lot of your expertise. I would also, at the end of this, love to come to Masood and ask him about the bias, the ethics, and the racism point. I think that's something that you've done in your career, you're really focused on. So, Victoria, there's a lot of things we've touched on. Public trust, talked about ethics. There's lots of things to go for. I'll leave it to you, up to you.
Well, I just wanted to start by coming back to Masood's point about data informed rather than data led. And I really like the way you framed that, because it's not just even about the quality of the data and the representative of the data. It's also the questions we choose to ask of the data, which also have their own inherent bias within them. So I think they're sort of bringing this sort of critical thinking at every step of using data to inform decision making and population health management and everything is so important. I just want to step back though and think about the sort of mood music sort of more broadly that these debates in healthcare are operating within, because there's a lot of public concern about the business models of Facebook and the big tech giants. So that sort of mood music in the background of sort of distrust, concern about institutions, worries about NHS privatisation are all sort of in the background, and they sort of inform how people react at an individual level or at a civil society level when it comes to how we're approaching data within the NHS. And understanding patient data, who are part of the Wellcome Trust, did a really interesting review of how the media are reporting health data. And what they found was that there's a lot of rumour, there's a lot of misinformation, concerns about private companies, these sort of broader issues. And so there really is a need for NHS Digital, the national bodies, to be much more proactive in terms of how they get the right and the correct information out there to the public. And some of this, Masood talked about just that sort of the overwhelming sense of all this data. And actually, it can be really confusing for people who are relatively well informed to get their heads around and understand even the role of opt-outs, for example. So I think there's the onus should be on the national bodies to really increase their transparency, their governance, engaging with civil society, and encouraging a much more transparent conversation that takes time rather than just trying to rush things, which always creates a backlash, and then you end up taking huge amounts of time anyway to get things done. So that's what I'd really advocate for, and really engaging well with Ada Lovelace Institute, with Understanding Patient Data and others to get a really high quality, informed debate that really engages citizens.
Thank you so much, Victoria. Great insight there. I'd like to just point out that we've got some questions that have come in. So we're going to go to those questions before we continue the panel conversation. Masood, one thing that I should mention from Otto von Arx. Masood, great angle, referencing your quote again, the Economist quote. And as a jobbing clinician, I often feel overwhelmed by data noise, most of it of little value to my patients. And I welcome a patient clinician end user focused approach. So something really agreeing with the thrust of what you were saying there. And I will come to you on the racism point now, Masood, something that you've worked against your entire career.
Thank you, Hassan. So absolutely, I think again, what's really important is that we're embracing AI and machine learning as this panacea for everything, but we don't always understand what it means. And so the example that Amy referred to, what was interesting is this was Amazon, and Amazon had their own developers had created these algorithms to kind of work out what's the ideal employee. Now, most of the developers were sort of quite young, white, male, and therefore when they were developing best, what's the ideal candidate, they were ultimately creating algorithms that were replicating themselves. And that's why the bias was actually reinforced through the algorithms they developed. And it wasn't until they saw that actually things aren't changing, the aim was to create diversity based on competency and skills. But actually what happened was that it was just reinforcing the current model. So again, it's just being aware that AI is not always the answer. The other thing is to understand, what does machine learning actually do? When we talk about machine learning and we talk about building neural networks, and actually where the models will start to teach themselves. And you gave a great example of how they recognized a ruler next to a skin lesion equated to a melanoma. Well, again, the connection was made. So what the machine learning did is it didn't prejudge what it was trying to assess. It actually looked for those connections, and the stronger the connection and the correlation, the more likely it was that that was going to be true, which is why you get to that situation. And what's really interesting, again, it's just being aware. And this is where clinicians often have concerns. They don't understand what's in the black box. And therefore they recognize there are inputs, they recognize there are outputs, because they don't recognize what happens in between. It's that sort of governance and assurance about how technology is being taken forward. And so an example that was referred to, I think it was in the Wachter report, was really about how sometimes mistakes are made and how our behaviors are kind of influenced. And one of the things that I've read is where if a computer, if you've got a decision support tool, and it says no to a certain action, there is more chance of the clinician trusting that and actually not taking action, rather than thinking, hang on, actually, even if the decision support tool doesn't give me any answer, what would I normally do? So that it creates a hesitancy and a doubt. And I think that's often what clinicians are worried about, is that if we start to have an over-reliance on the tools and the data and the tools we have, what does that mean in terms of our own decision making? And that's why I kind of started off by talking about the noise and what we need to make, having that data informed approach, because I do think it's essential. I do think it helps us, and moving moving forward, you know, James referenced this, that, you know, we're overwhelmed. And so when we talk about transformation, what does that mean? Well, transformation is really changing. It's a real paradigm shift. It's changing the way we work. It's changing the way we look at things. It's really engaging those opportunities. It's not about, you know, those little incremental changes, because we've been doing that within healthcare for years. It's actually about being open to disruption. You know, what are the game changers? What are, you know, what can we do? And that's why it's so important to make sure that actually we have the right infrastructure and we understand how do we make all of this available, because there is so much opportunity. We're moving at such pace that actually we need to have trust in the infrastructure that we have, so that we can leverage that for, you know, for innovation, and use that as a springboard, not just a platform, but a springboard for how we move forward.
Thank you so much, Masood.
A few things there.
You did, and we can go in a number of directions in this conversation. I just want to pick up on one point in the Q&A. Ian Rubin, his comment: in the US, if you're neonate requiring resuscitation and Black, you're more likely to survive if you're resuscitated by a Black doctor than a white doctor. If you are white, the color of your doctor makes no difference. So we can see that there's already bias in the system even before we go into AI. I think, Amy, you had a point about this on that Nature article.
Yeah, there's a Nature article, which is the one I was referring to, that there's a decision-making algorithm within the US healthcare provider system, and it would refer more white patients on for onward treatment than it would Black patients for the same level of sickness. So Black patients ended up having worse outcomes, and that was embedded into, I don't think a human actually checked that, because the algorithm was built and then it was done, but because the data was there, it made that kind of research to prove the racial bias a little bit easier. So in some respects, the data is helpful there, because what has previously been thought of as anecdotal or ignored or thought perhaps wasn't as important or real as it was, that race, that, you know, Black people have been saying there's racism in healthcare in the States for a long time, and now they actually do have evidence thanks to the data. So although the data is doing a bad job, you know, it's proven a point for them to hopefully try and improve things in the future.
Thank you so much. And there's a comment in the Q&A. This is from Raymond. Data is the new oil, but just like oil, it requires refining, testing, and launching. We don't have machine learning that is as smart as the data, and they're influenced by the environmental factors. So I think there's lots of agreement there. There was a question in the chat that I think I want to give to Victoria. It's about New Zealand and Virginia Mason. Can the NHS learn from Virginia Mason and others and have its production system to help operationalize implementation of technology? Pete Davies has asked this question and says I'm sure there's homegrown examples, but he doesn't think there's any in his patch.
This is a really interesting question, and we've already referred to Bob Wachter in this session, but he, of course, in the Digital Doctor said that IT is the master of all adaptive challenges, and I think we ignore that at our peril. And Cooper, who some of you know, who used to be Chief Nurse at NHS Digital, also once said, don't underestimate the ability of a group of nurses to kill your digital project. And I think if we don't pay attention to people, to complexity, to behaviour change, to culture and leadership, then we're going to fail. And Virginia Mason is a service improvement methodology, of which there are a number in the NHS. And I've been working with an NHS trust in the South, helping them think about how they introduce design thinking, so service design, which is really emerging as a discipline within the NHS. And we've got a number of roles emerging within digital teams now, which is really encouraging. But how you bring that sort of intentional design to digital services, but also how they're deployed within a context, about how they might shift the workflow, about how you might redesign a pathway enabled by technology. I was thinking if you just plop the technology on, then you just create a whole load of ripples and unintended consequences. So I think there's something about service design as a new discipline, about QI, quality service improvement, and how you blend some methods in there, along with patient and public involvement, which is often very established within NHS organisations, and then your digital transformation teams and your OD teams. So I think we have a load of assets within the NHS. But in my experience, you often find digital and IT teams never thinking to talk to the QI team, who never think to necessarily talk to PPIE teams. And so there's something about how can we bring those assets together to support digital transformation? And then how can we leverage design thinking? And I know there's a real national push from NHSX and a working group that NHSX, NHSD and Tech UK have got that I co-chair, to really try and embed this approach much more substantially than it is at the moment.
Super, thank you so much, Victoria. James, I haven't come to you for a bit, so I've got 2 questions for you from the Q&A. I'll let you decide the order. One of them is from, I've got to call him a legend, Suki Panesar, and said, Masood has used my favorite word, disruption, and going beyond incremental change. Do ALBs, the arm's length bodies, need to do more positively disruptive stuff? Masood's already given a comment. We need to be bold and embrace opportunity. So that's question 1 for you, James. The second is from James Pethick. There's so many different IT systems in the NHS, and I suspect healthcare more generally, lab results, radiology results, medication, diagnostic histories. How do you get all the relevant data into the algorithm? So I'll leave both of those for you, James. You decide the order.
I'll actually take them in order. Thanks, Hassan. So Suki's absolutely right. You know, arm's length bodies do need to be disruptive, and I don't think they've gone far enough in the past. I think we have had this challenge with, and actually I'll bring the 2 questions together. We've had this challenge with the legacy applications being developed in isolation in different hospital providers working across a region, but you know, you go to another health economy, they've created their own version of the same database, the same capabilities with slightly different data sets. Never the twain shall meet, in that you can't actually analyze or share the data between them, which has caused real challenge. But part of this is that we keep coming out with these national systems. We keep coming out with, you must take this, you must take that. And it loses the agility for people to come in with new capabilities at a local level, where you're bringing in SMEs or AI companies to actually bring a new algorithm or a new treatment or a new application that can add value that the rest of the NHS can learn from. And actually, at the start of COVID, we did learn, you know, very early on that there were all these niche players out there that actually people didn't know about and couldn't scale. And Hassan, you Masood, you know, Amy, you know, you were part of one of those communities that was bringing those players together to create that disruption in the service. Now, that needs to carry on, because you know, you get these great ideas that come out of nowhere almost. They're specific to a need at a local level, but other people don't realize that they're suffering the same problem. They just haven't hit that challenge yet. And if you're hamstrung by, you know, one model of care that actually is not flexible enough to change to the way that you provide care locally, it becomes a problem. And if you look at all the different data applications out there for digital pathology, EMR, cardiology, ophthalmology, you know, you can, and on and on and on. They're all in their own data silos. So getting that data together is a real challenge. There's been a lot of work around standards and messaging formats and getting people compliant. But there's also been a lot of work to understand how can you actually move the data, because that in its own right is a challenge. You know, some of these are huge data sets. You know, it's a real struggle to get it across the internal network, let alone move it into an external network. And then, of course, there's the cost of moving the data. You know, if you start going down the whole cloud first agenda, you know, where you're trying to move your data in and out of a public cloud provider, you're not getting the real benefit of where the cloud comes in, which is around compute and, you know, interoperability and capability. You suddenly start to get hit with the cost of the ingress and egress fees, you know, and people start to forget about the value because they can't afford it, and you know, they've got this balance. So really, what we've been trying to do within DELL Technologies is work with customers not on a technology solution, but a technology approach as to an architecture of how you can start to bring different technologies together to give you that agility for new applications down the line to be brought in, to enhance the security, create enclaves for secure data collaboration between research, pharma, health economies, and health economies. You know, that's another area that you know, we've not been great at in the past because of, you know, consent, because of the bias in the data, the demographics, you know, having that ability to share. You know, so looking at how can you reuse, you know, the technology that's already been invested, but actually bring it together in a way that gives you the ability to get new insights that you can then share out with the rest of the NHS. You know, this isn't about putting in a big system. This is about reshaping the way the data is analysed, creating a data fabric or a data highway, as we like to call it, where you're able to bring the data and the outputs of that data and make that outcome available rather than the actual data being shared. And there was another question I noticed from Simon around the care.data. The care.data wasn't just scaremongering and misinformation. You know, that's a bit flippant to say that was all it was. It wasn't. There was misinformation and misunderstanding about its use, but also, you know, the approach of how the data was going to be made available, you know, needed to be rethought. And really, you know, in terms of the security model that needed to be applied to it and the outcomes of that data, that was really where the benefit was going to come. I was involved with a lot of research organisations back in the time of the care.data who were praying that the care.data programme would go ahead because of the richness of the data it would give them access to. And when it was canned, you know, they were saying this has put research back 5-10 years in the UK. You know, now that might have been an exaggeration by some of the researchers, but I got the feeling, you know, I understand what their problem, you know, what their concerns were, which is we were getting access to data that we'd not been able to get access to before. And suddenly we could see the opportunity for how this was going to accelerate research. And suddenly to have that pulled away from them, you understand the blow. Actually, if you can restructure the way that data is captured now in a way that enables you to bring in, you know, applications from an AI vendor, you know, whether that's Viasu for a data fabric or Stardog or Boomi or you know, whoever, doesn't really matter. You know, enable you at a local level to be able to convert the data around what you need to do rather than just, you know, a national policy. You know, the whole point of the ICS, and Masood, I'd love to get your thoughts on this, is shaping the technology and the information that's being captured for improving the services at a localized level, going beyond just health, but bringing in social care and that whole transformation with the local authority to reshape it all, which means broader data set, but it also means new ways of interrogating the data. So I'll stop there, sorry.
No, thank you, James, because I was going to go to the other panelists with some prepared questions, but I think the question that I really want to ask was going to be about how do we get the next generation, right? And James, I'm going to come to you with that question. I think you touched on it in a number of ways in what you've just said. So it makes sense for us to continue the conversation. What are DELL Technologies doing for the data fabric? And importantly, how are we breaking the silos? How are we making sure that the information is in the hands of the right people at the right time? You know, the right information at the right time. That's the I think the need that we need to go through.
Yeah. No, and that's a good question. Thanks, Hassan. So, I mean, within DELL Technologies, we've been working with researchers and pharmaceutical companies for tens of years now, helping them to build data repositories for analysis. And in the last 18 months, we've seen this, you know, this real change in the mentality of, you know, from working in isolation, who can win the race to get to the newest treatment and drug, to let's start collaborating and let's start working together with health and higher education in terms of the universities and the colleges. And what we've been doing is we've been working with research companies, you know, such as you know, Partners Healthcare or Massachusetts General Brigham, as they're now known in the US, with pharmaceutical companies such as Pfizer, you know, AstraZeneca, where we're looking at how we can bring together collaborations with the research companies and the pharmaceutical companies, where there's a common aim and a common system. But it's not easy to just say, well, we connect people up. The infrastructure, the software, the applications, and the way that people engage also needs to be done. So what we've done is we've designed and pulled out a new paper around the data fabric and how to digest that data to take advantage of technologies that are already out there. Some are ours, some are others. Who it belongs to is not the point. The point is, how can you consume the different technologies available to you to make that data available in the most appropriate way to add value to the clinician at the time when it's needed, whether that's through training of AI algorithms, whether that's through bringing systems out of the electronic medical record and making it visible to others. More importantly, bringing the patient into the decision making at the heart and having the ability for the patient to have access and control over how their data is used, but also the ability to add to that data through personalized things, through the use of wearables, capturing the data that's going on a 24/7 basis, not just when we're in a stressed environment in the hospital. So really, we've started to take an approach which focuses down on a number of key areas. So, and we like to call these pillars of transformation, underpinned by technology. So focusing on connected workforce, focusing on precision medicine, looking at the technology platforms underneath that can scale out and can connect to all the different applications that are out there. Because the whole point is you need something that's open source and based on open standards with open APIs so you can connect new technologies in. We've seen in the past this lockdown mentality where we've brought in clinical systems that we can then not get the data out of, we can't make use of. We're having to go back to the providers to pay them to do all the analysis for us. We've actually created a silo of our own data, and worse still, it's an ongoing cost to the NHS rather than having that freedom to analyze the data and use it for new care pathways and find these new treatments. We actually find we can do less with these new applications. So creating a capability that opens up the data in a secure manner, which, and I come back to that secure manner and appropriate manner, because we're not in this position of saying, well, we'll give everyone access to the data and do what you want. The patient has got to have confidence that their data is being used for the right purpose, but it's being used appropriate with their consent. At a higher level, though, you don't actually need patient data. You can use distributed analytics to analyze the data at source and just get the outcomes and start to understand how different data correlations can come together to give you new meaning. So you don't always have to go down to patient level data. And people forget this. Outcomes and operational activities are also important, but you need to understand how the data comes together. And there was another great data comment being made in there, who's that from? Pete Davis, about understanding the significance of the data you're analysing. So I used to work in the information departments at the regional office, working with the epidemiology teams, where if you looked at one set of data in isolation, it would make no sense. And you could be scratching your head trying to work out why there was variations all the time. However, once you understood the data, you could start to bring different data sets in alongside, such as, pediatric admissions went through the roof in certain parts of the country at certain times of the year. And if you looked at it, you think, well, why was that happening? Well, school holidays, and they all went on holiday, they went down south, and suddenly you'd see pediatric admissions from patients hurting themselves down south. But you'd see a reduction in the Midlands where no one wanted to come on holiday. Everyone left, en masse. But also football, events or, big, music shows and music events. You could start to use the data to plan activity levels. And also, if you linked in with the Met Office, you'd understand about cold fronts coming down. So, you know, fractured neck of femur, we're going to have higher levels of those because of ice on the road. You can use that to be intelligent in your planning. Exactly the same with using, you know, the AI data sets, is that you need to understand the significance of the data. And this is where the bias that comes in can be a challenge. So if you've created an environment where you're able to put governance and policies in that enable you to understand not just how the data is stored, the security of it, or the applications, or who's using it, but also apply the policies at a metadata level and be able to refine those policies for the different data types and bring the correlations together and then share that with other people. That's what we're doing as part of, you know, the work that we've encompassed. So we've actually rolled this out in a number of areas in terms of research, where, as I said, we've supported open access to data so that people can start to do this. We're building out digital twin capabilities. We're leading on, with the Digital Twin Consortium globally. We're helping to support standards for what a digital twin could look like, and also that capture of synthetic data so that researchers and healthcare organizations can run scenarios against the data and get better insight. But you need to have that data capability model around governance. How are you going to work, whether you're working with, multiple cloud providers, multiple AI applications, how you can orchestrate and create catalogs of the data. All of these need to be thought about, and we pulled together that reference model to make it easier for organizations, whether that's at a government level or whether that's down level, GP level, to take advantage of these rather than having to reinvent the wheel every time.
James, thank you so much. So what I'm going to do now is take some of those thoughts and bring them to each of the other panelists and ask them what would happen in their areas if we were able to have those advantages that you've just mentioned. So Amy, I'll come to you first, right? There's been lots of conversation about the benefits of EMRs, right? And medical imaging and digital pathology and having the data in the right place and enabling secure patient care. If you were able to make sure that the data was in your hands at the right moment, if you were able to make sure that there was no issues around trust, so the algorithm went to the data, would that make your job easier? Is that the kind of thing you're looking for?
I think that there was a big push for EMRs pre-COVID, and a lot of work went into it, and very few hospitals have a full EMR platform where everything is actually integrated and in one place. And those that do, I think, it doesn't necessarily work in the way that they thought it would. But I think the pandemic has pushed forward telehealth and digital health and remote access. And I think we've come out the other side, and EMRs are a little bit defunct now. They're a little bit old fashioned. That one single platform is not bespoke enough for what you need in healthcare. Healthcare is so diverse. What I need as a radiologist is not the same thing as what the pathologist needs. There's a lot of overlap, obviously. And I think we're moving towards realizing that we need more bespoke solutions. So something that works in radiology for me would not work for a GP or a consultant in a hospital. And so I think a better solution is that we have a standard that enables different bespoke technologies and ways to amalgamate and collect data that allows interoperability and open API access, so that because some of the bigger players in the market now just don't open their APIs, or they're a little mini cartel and they charge 30 grand. So for us in radiology, if we want to integrate into a RIS system, a lot of the RIS providers charge us 30 grand for nothing really. And if you're integrating into the same system twice in different hospitals, it's still 30 grand per charge, and it's like a day's work for them or something. And it slows down change in the NHS, and it puts a lot of stumbling blocks on, and it increases the cost for the NHS as well. And I think if you have standards that say technology that you're bringing in and building, and the way forward is to have that interoperability so systems can talk to each other and you can share data with who you need to, so that you've not got one place that has everything but you're overwhelmed and you don't know what to do with it. That would be my suggestion for going forwards.
Thank you so much for your perspective on that, Amy. Victoria, we discussed this question way before we started the presentation, but it's about closing the gap on health inequalities. It's about building inclusive and representative data sets. We want equity and we want innovation. So Victoria, if you saw a future that was similar to what James was proposing, would that make your dream come true?
I don't think there are any quick fixes to this, to be honest. I think the extent of social and digital exclusion became really apparent during COVID, in a way, the first wave of COVID, in a way that just wasn't apparent or understood before. And I think, if I'm honest, I saw a lot of lip service to the issue of digital and social exclusion beforehand. But I think, thinking about children not being able to have laptops to do their schoolwork and so on, it was really sort of in our faces, which I think was, it was great that it did highlight those disparities. And I guess we've got a bit of an issue when we're thinking about patient-generated data, of the inverse care law being sort of repeated or made greater, because the people who would most benefit from technology are the people least likely to be able to use it, have access to it, or have the trust, motivation, confidence to engage with it. So then we create data shadows. That means we generate bad quality data because we're missing crucial people. So I think there's not a quick fix to that. I think there's some really interesting work going on. So again, I'm working with another trust that has a really good digital inclusion project. They're buying devices and giving them out to patients, but as well as that, they're looking at digital skills, digital confidence, their duty of care. So it's sort of, there's some nuance and complexity to it. And of course, this is where collaboration with local authorities and the third sector becomes really important, because they're often much better set up than the NHS to deliver these sorts of projects. And I think in the NHS, when we look at digital inclusion projects, we tend to think very narrowly about somebody using an app rather than the broader benefits of digital inclusion to people's socioeconomic status, which has an indirect effect on their health. So I think it's really important that we think about this systemically, we think about it across sectors, and ICSs build this into their programs and take it and fund it, because it needs resourcing. And then when we start to get that better quality data, then it becomes, how do we bring together, we've already discussed those different sources of data from different sectors, so we get a really rich picture that informs good population health management and good direct care. So I'm not going to give you a simple answer, but anything we can do to bring those data sets together, improve them, but we've got to think about it from a citizen perspective as well as from a platform perspective, I would say.
Thank you, Victoria. The question was tongue in cheek. I'm sorry, I'm getting a little bit of echo and feedback. If you wouldn't mind going on mute, thank you. Victoria, the question was tongue in cheek because I think the answer cannot be either or. It's not about getting the data in the right place and also working on the culture and the inclusivity. It's about making sure we touch all of the bases in the right order. And digital transformation, as we've heard many, many times, is about the people, right? So thank you so much for that answer, Victoria, and it wasn't meant to direct you in any way. Masood, the question that you and I discussed before the session was about population health and the challenges that ICSs and the CCGs and the integrated health and care teams that are starting up, for example, in Dudley, what exactly are their needs, and how would an approach where you're able to do what James was talking about support that? And I just mentioned that we have 6 minutes left in the session.
6 minutes, so I'll be quick then. I think first thing I do is build upon what Victoria said. It is really key to recognize that digital inequalities will be exacerbated if we don't go to the fundamentals. So exactly what you've said, we're doing that in our ICS because we're the second most deprived ICS in the country, and we're extremely diverse. So, those pockets of social deprivation and so on, it's really important to go back to the basics, having kit, having connectivity, and having the skills. So again, we've built a program around that where we are going through and linking in with the voluntary sector, social prescribers to kind of engage. And that's the groundwork that needs to be done. But I'm going to flip the model a little bit. We talked about diversity and inclusion and sort of for our population. Actually, we also need that for our staff. As we go to move forward in terms of ICSs, we're talking about collaborative models. We're talking about multiple stakeholders coming together, trying to solve these big problems. And that means in terms of our teams need to be diverse and they need to be inclusive. I'll give you an example. We've got a primary care leadership team. So they're called Primary Care Clinical Leadership Executive, PICLES. Our PICLES have traditionally been very much focused on GPs, as GPs being the representatives of primary care, but actually it's more than that. So when we've recruited Pickles and the model we've built around leadership, we've actually brought in pharmacists, we've brought in nurse practitioners, so we've got that diversity. And we're also focusing on the skills they need to understand the challenges. And I think this is where actually linking in with the commercial sector is really important. I know one of the questions was about how are we going to do this? How are we going to train our staff? Actually, we need to leverage the expertise that is external. A company like DELL is working globally. They understand best practice. How do we link in with companies like that to help support us? And I think the other thing is really just to recognize the approach. What are we talking about here? Well, we're talking about long-term investments. And so I think another question was about how do we fund all of these changes? Well, we've got to be very clear about this. We can't always be looking at capital investment for an in-year return. That's not the way forward. If we are looking at population health, then actually the change around healthy life expectancy and so on and so forth, reduction in smoking, tackling obesity, these take years. And actually, we may not even see improvement post-pandemic. It may be that we're just trying to stop the health inequality gap widening. So we have to appreciate that actually there's a concept that Muir Gray talks about called stewardship. How do we come together with our different hats? How do we understand each other's perspective? And how do we make decisions together that actually mean we may not see the benefits for years to come? But we have to be bold enough to commit to that investment, knowing that that's the case. And that's where I think you've got new models of care. And you mentioned Dudley. Dudley they're the first integrated health and care trust in the country that are being set up. They're looking at bringing the patient at them in the middle, and actually a multidisciplinary team that doesn't come together once a week, but actually is together every day, which means that the patient, the carers, the family it's that holistic approach. And that's where population health then starts to play its role, because actually we need to understand the dynamics of the citizen as an individual, but then be able to scale up to a population. So everything we do has context, and all of these things are important. None of them can be looked at in silos. So we need to have that broad lens. We need to be responsible together. We need to think about what it is we want to do, and we need to be able to invest for the future and not expect returns by within that financial year.
Okay, wonderful. And I think we've got to a great place in the conversation. What I'd like to do is ask the panelists to help me answer one or two more of the open Q&A. I'm going to ask you to keep the comments very, very brief, like 20-word answers if you could. And we'll just get through a couple of those. Then I'll ask for your closing comments, and then we'll say goodbye. So as an example, Aaron Cox has asked, there's lots of scaremongering around sharing data. Is there any work being done to bring the yin to that yang, balancing the value of people and service improvement? Any quick answers on that? Victoria?
I would definitely look to the work being done by Understanding Patient Data. They've got great resources aimed at services and citizens around the value of data, and they're really trying to influence the NHS, national bodies, to get much more engaged in managing the media proactively. So I would go to Understanding Patient Data.
Wonderful, thank you. Completely agree with you there. Emily Birch, with the importance of data and being able to analyze it, how can mental health trusts, which have often been woefully underfunded, take advantage? James, is that one for you very quickly?
Sorry, I was trying to find that question. Which one's that? From Emily, did you say?
Sorry, James, while you're looking for the question, one of the things is actually tackling this collectively. And again, the problem is not for mental health trust. The problem is us as a place, as a system. So again, as stakeholders, what we can't do is say, well, you're underfunded, you're overfunded, etc. What we need to understand is the funding flows, and how do we adapt those funding flows to ensure that actually we're investing in the right areas. Mental health is a huge priority. If we look at the data strategy and data saves lives, we're seeing the impact of the pandemic. Things are only going to get worse. So should there be additional funding? Absolutely, but not in isolation. That additional funding is within the perspective of what else we're doing within the system.
Yeah.
Thank you so much. Yes.
Sorry,
James.
I'm sorry. I see the question now. Yeah, the real challenge in mental health is the disparate nature in which you're communicating with the patients. You know, typically patients are outside of the hospital environment. It's difficult to get them engaged in providing data. So using technology to remotely capture data, even if it's something like a wearable or something easy for a patient to actually have on them, so that data can automatically be captured with their permission, that gives automatic alerting to a consultant or physician nurse about the patient's well-being, you know, will help. But ultimately, you know, we need to look at different ways in capturing the data, not just through the patient record, but looking at social, you know, sense data and from carers as well.
Thank you so much. So I'm going to ask for closing comments. I'll go to Amy and then to Victoria. And if you wouldn't mind, we'll keep it slightly brief and then we'll sign off. Amy, over to you for closing comments, please.
Just to say that I think we need to embrace the digital change, but not forget about the people behind it. We didn't really touch on this, but you can have great technology, but if you don't engage the people using it and the people at the end of it, it's not going to go anywhere.
Thank you. And that's a great segue into Victoria.
I sort of feel like I can't really add to that. That was a great point, Amy. And I think that line of a vision from the citizen to the population and digital as an enabler and never forgetting that contextual piece is my final point. Thank you.
Wonderful, thank you. Then Masood and then James for closing comments, please.
ICSs, I think, are a great opportunity, and I feel very privileged to be in the mix, you know, shaping that future. The key, though, is collaboration. And what we need really is to embrace the mindset that is about true collaboration. So we're not protecting our own fiefdoms. We're actually truly working together, and that it's for the patient, for the citizen. And so we've got the form. We have to work out what's the function, and then we have to work together to deliver on that, on the ambition.
Thank you. Final words, James.
I fully agree with everything that's just been said there. Yeah, the patient has got to be at the heart. What we're doing here is how can we analyse the data to improve patient care? And we mustn't forget that. This isn't about redesigning the NHS. This is about supporting the NHS, using the data that's being captured and the tools available to us to make insight that we can then pass back to carers to actually improve the care that's being provided, but with the patient at the heart of that, in terms of redesigning services that improve the pathways of care and access to services.
Excellent. So I'd like to give an apology that we've run over slightly. That was my fault as chair. My thanks to Masood, to Amy, Victoria, and James. You'll see underneath their portraits, you have their Twitter handles. Please get in touch with them and keep the conversation going. They genuinely are experts in their fields. Huge thanks to DELL Technologies, our sponsors for this webinar, and a reminder that there is time to register for the big HETT conference. You can register free at hettshow.co.uk. And if you want to know more about DELL Technologies and what James was talking about, you'll see his Twitter, his LinkedIn, his email, and his website there. Thank you so much for joining us, and I hope you'll see us soon. All the best and take care.
Thank you.